My name is Bijan Teja, and I'm a critical care physician at St. Michael's Hospital. I'm also an assistant professor of anesthesia at the University of Toronto. I'll be talking about the latest on steroids and sepsis. I have no conflicts of interest to disclose. I do have funding for research on septic shock from the Canadian Institutes of Health Research, St. Michael's Hospital Alternative Funding Program, and Sunnybrook Critical Care Foundation. I'd like to say a special thank you to Nick Bosch and Alan Walkie. We collaborated together on a How We Do It article in Chest about escalating vasopressors and initiating corticosteroids in septic shock. So today I'll be talking about the newest evidence on steroid selection in septic shock, including our recent paper in JAMA Internal Medicine. We'll be talking about controversies about steroid initiation and tapering, and a brief overview of future directions. When I was first starting my career in intensive care medicine, I was sitting down for a coffee with a colleague, and he said, I have this great app called Joule. It allows me to actually keep track of all of the original papers that I'm interested in. And I said, that's great. I like to read original papers too, but why sort of have them on your phone with you all the time? And he said, well, because when I'm thinking about, initiating a therapy that I heard or I read worked in a trial, I tend to want to do exactly what that trial did in terms of the regimen I initiate. And I said, okay, that's interesting. And then a couple of years later, I was in the unit, and I had a patient with septic shock, and the two trials from Venkatesh and Anand had just come out, and I hadn't really read them in detail yet, but I was about to start steroids on my patients, on one of my patients, and a colleague of mine said, "Hey, um, I saw you're initiating steroids," and I said, "Yes, I'm just going to do hydrocortisone Q6." And he said, "Well, why wouldn't you use fludrocortisone? It's the regimen that they used in the trial that showed benefit." I thought, "Oh, interesting. I wonder why that is." And so I wanted to look into it more. And so, as you may know, there's 5 major trials in septic shock um, of looking at corticosteroids. The two that have shown a mortality benefit both used hydrocortisone and fludrocortisone together, the Approaches trial and the 2002 Anand trial. The Venkatesh trial from 2018 showed maybe some improvement in secondary endpoints, but no difference in 90-day mortality. So it was a decrease in the duration of shock, but no difference in mortality. And then Vanish and Corticus showed no difference, and they used hydrocortisone alone. And so, the first element that I wanted to talk about in this discussion was the case for fludrocortisone, because most people, at least from the practice patterns we've seen previously, hadn't been using fludrocortisone. But my practice is to use fludrocortisone, and I think that more people are adopting that practice based on some recent literature that I'll show. And so Anand, the author of the 2 trials that did show a benefit of steroids in septic shock, he wrote a nice piece in Critical Care Medicine about why my trials were quote unquote positive. And for one, they included sicker patients, but they did also give fludrocortisone in addition to hydrocortisone. And he sort of shows the trial and interventions and the absolute reduction in mortality. And you can see that both of his trials had a 6% absolute reduction in mortality, and both of those trials used hydrocortisone and fludrocortisone together. There's also one trial, also by Anand, comparing hydrocortisone and fludrocortisone together. It was also looking at insulin therapy and septic shock. And it showed a 3% absolute mortality difference. And now, while that would be clinically important, they would have needed 5,300 patients to actually detect a 3% absolute mortality difference, whereas they had, only about 550. And so, when I started thinking about this, I said, what was bothering me the most was, why would adding fludrocortisone improve outcomes, because when you look at the mineralocorticoid equivalents from published tables, you can see that from the typical regimen, which would be 50 Q6 of hydrocortisone, you would get 200 mineralocorticoid equivalents. And when you add fludrocortisone, even though it's 125 times stronger, you're only doing 50 micrograms. And so that would add 6.25 mineralocorticoid equivalents. So why would 206 be different from 200? And I think the critical piece here is that when you look back to the original tables, like from the physiology textbook, Goodman and Gilman's, and you'll see that, how would they have come up with mineralocorticoid equivalencies? Well, they just looked at sodium retaining potency of the kidney. And that is an oversimplification of what fludrocortisone would do. In fact, there are many other functions that we'll talk about briefly. And so when we were writing this paper with Nick Bosch now in Milwaukee, we came to the section on steroids, and I said, well, I give fludrocortisone and hydrocortisone together. They said, well, we've just done hydrocortisone, but I wonder if we can look at this in a large database and run a target trial. And we actually found that same 3% absolute risk reduction in the target trial emulation from the addition of fludrocortisone to hydrocortisone. Essentially, it's 2.26% of 88,000 patients had received hydrocortisone and fludrocortisone together after we excluded, patients who were under 18 and alternative indications for fludrocortisone among septic shock patients. And the nice thing was that we had similar baseline characteristics. So, whether someone received fludrocortisone or not was more just a function of the treating clinician's preference than their baseline characteristics, which makes it ideal for a target trial. And we found a 3.7% absolute reduction in the primary outcome, which was hospital death or discharge to hospice. Also 3.7% reduction in hospital deaths, more mean vasopressor free days, and more mean hospital free days. And so, what is it about fludrocortisone beyond sodium retention, which may be driving this potential benefit in mortality? Well, hydrocortisone, there's actually many mineralocorticoid receptor isoforms. And while some of them bind to hydrocortisone, others cleave hydrocortisone immediately, at the site, and hydrocortisone essentially has no function on those receptors. And the fludrocortisone, activates the innate immune system. It increases lung water reabsorption, which is probably relevant for many of our septic shock patients who have, ARDS or pulmonary inflammation. And there's many other cardiovascular and CNS functions, and we don't have a great understanding of these yet. But I think there's enough potential mechanisms that would make this benefit plausible. Another interesting study called the HYPRESS study enrolled patients who were not in septic shock but just had sepsis, and they looked at both the mineralocorticoid pathway here with the corticosteroid as the precursor, and cortisol glucocorticoid pathway with cortisol at the endpoint. And they looked at those steroid profiles and stimulation profiles, and they found that while the glucocorticoid pathway was not associated with death from sepsis, impairment of the mineralocorticoid pathway was, which suggests that maybe mineralocorticoid pathways have an important role in sepsis survival versus non-survival. And so for our JAMA-IM paper, they interviewed Michael Mathey at UCSF, and they asked him, have you changed your practice? And he says, I've definitely changed mine and recommended that our group of critical care physicians consider as a group doing so at UCSF. And when I presented this earlier this year at the CCF Academy, initially, 6% of people said they used hydrocortisone and fludrocortisone together, And at the end of the presentation, we had, the same 5% who said they would continue, but an additional 79% said, I previously used hydrocortisone alone, but am now considering adding fludrocortisone. And I think part of the reason for the change is also that the medication is relatively cheap and well well tolerated by patients. So one question that comes up often is fludrocortisone absorbed enterally? And this has actually been studied by Anand's group. They found that out of 14 patients with different, I believe it was different forms of shock, out of 21 patients, 14 of them after the first dose had a detectable level. And so, at least 2/3 are going to be absorbing the oral fludrocortisone, and that's after just one dose. So you would expect that after 7 doses, more patients would have absorbed it. Another question is, what about patients with renal failure? Because people worry that maybe fludrocortisone will decrease urine output or kidney function, but actually, in the most recent Anand Approaches trial, 27 to 28% of patients had renal replacement therapy at baseline, and there was a mortality benefit in that study overall. And in another paper in intensive care medicine, where they had looked, I think they had looked at the 2002 Anand study, they found that low dose steroids improved both gluco and mineralocorticoid, both of those medications seem to improve renal function. And then lastly, what about hypernatremia? Well, we found in our study a similar proportion of patients with incident hypernatremia with hydrocortisone and fludrocortisone versus hydrocortisone alone. So no difference there. And remember, the sodium retaining potency, which is what the mineralocorticoid equivalence tables are based on, would suggest that hydrocortisone has a much bigger influence on sodium retention than the small equivalents from fludrocortisone in that particular physiologic piece. So my recommendation would be to use hydrocortisone and fludrocortisone based on what we know now. And next question is, when should adjunct steroids be started? As you may know, the Surviving Sepsis campaign guidelines suggest from 2021 suggests that to really think about it in patients with an ongoing vasopressor requirement at about a norepinephrine or epinephrine equivalent of 0.25. That's a weak recommendation, and that systematic review did not, or that guideline did not incorporate the systematic review by Rochberg in 2018. In that Rochberg study, they had looked at an interaction analysis of sepsis without shock versus all others, and they didn't find a significant interaction there. And so, for some people, they might suggest, well, the benefit may still be there, the potential benefit may still be there regardless of the degree of shock. It may just not be as pronounced if the baseline mortality rate is lower. And so personally, I don't feel strongly about this. I think, as I tend to only start steroids at a norepi dose of 0.25 or 0.3, but I don't think it's unreasonable. Sometimes people give steroids as a way of, preventing a patient from going into shock and coming to the ICU. I don't think that's unreasonable. We don't have enough evidence yet, I think, to say one way or the other. And what about whether steroids should be tapered? I think there's only observational evidence, and when we did our review for the chest paper, we found that some suggested taper might be beneficial, some suggested it wouldn't be, but this has never really been compared head to head. And my approach has been to just do what the Anand study that showed a potential mortality benefit did, which is just to stop after 7 days. And if the person has, a rebound of their shock or they get sick again, then I would restart steroids and also just do an, workup for other causes of shock as well. And finally, what about future directions? Well, there's several papers that have come out looking at different immune phenotypes and biomarker profiles that may predict whether whether a patient would benefit from steroids or potentially be harmed by them. And this work is in very early phases. And when I reviewed this for up to date, it wasn't clear to me that they were all looking at sort of different biomarkers, and this research is still in the very early phases. So I think for now, you know, I don't think we can use biomarkers to guide us in choosing who we initiate steroids for, but maybe something that we can do in the future. Another study we have in the pipeline is a network meta-analysis comparing fludrocortisone and hydrocortisone to hydrocortisone alone, and also to placebo in a network meta-analysis. This has already been completed. It's under review, and I think other groups have similar meta-analyses registered online. So there may be a few similar publications coming out, but out of 7,553 citations, we had 17 randomized trials that were included, including 2 trials directly comparing fludrocortisone and hydrocortisone to hydrocortisone alone. And we found that fludrocortisone and hydrocortisone alone, and hydrocortisone together compared to placebo, had a 98.3% probability of superiority, and fludrocortisone plus hydrocortisone compared to hydrocortisone alone had a 94.2% probability of improving the odds of survival to the last time point of follow-up in the studies. And this is consistent with a recent publication in New England Journal of Medicine Evidence. This was a individual patient data meta-analysis by Anand and his group, where they found that fludrocortisone and hydrocortisone was ranked the best therapy compared to hydrocortisone alone as an infusion or a bolus. And they found that compared to placebo, the risk reduction was 0.88 for mortality, with moderate certainty of evidence. So a summary, this is also available in the chest paper we published, and there will be an update to the up-to-date article as well. But essentially, my suggested approach would be that if you are deciding to use steroids in septic shock, consider using hydrocortisone 50 milligrams IV Q6 plus fludrocortisone 50 micrograms daily for 7 days without taper. Typically, we would use it in refractory shock, i.e. like norepinephrine or epinephrine doses approaching 15 micrograms per minute or 0.3 mics per kilo per minute. And if shock recurs after cessation of steroids, consider restarting steroids and also initiating further evaluation of causes of shock. If you have any questions, I'd love to hear from you, or suggestions. Here is my email and my phone number. Thank you very much for listening.